And Dr. Renu?
Hello.
Yeah, hello. Can you hear me now?
Yes, ma'am. Yes,
Thank you,
ma'am.
ma'am.
Okay. All right. So
Evening.
I
Ma'am,
will be there for first half maybe, but then my OPD is still going on. So
No
perhaps
problem.
I'll leave after the
No
session. Huh?
problem. I'll be grateful, ma'am. No problem.
Okay.
Ma'am, Bhagya ma'am is there.
ma'am, am I audible?
Yes, Bhagya, you are.
Yes, ma'am.
Uh, Mukul, are we ready?
Ma'am, we are ready. We are live.
Okay. So good evening to all of you. And I have Dr. Bhagyalakshmi with me, who is going to be the master of ceremony of this show. And I'm just handing over to Bhagya to start this thing,
Yes, ma'am.
webinar.
Yes, ma'am. Thank you, ma'am. Good evening, everyone. It gives me immense pleasure to welcome you all to this academic program of Indian Fertility Society, SIG Early Pregnancy, organized in collaboration with the IFS Rajasthan and Haryana chapters. So today's program, First Trimester Ultrasound, Beyond Dating and Viability, is particularly relevant because of the role of first trimester ultrasound has evolved tremendously. And we have moved beyond simply answering three basic questions like, is the pregnancy intrauterine, is it viable, and what is the gestational age? So today, the first trimester ultrasound offers an opportunity for early fetal anatomical assessment, placental evaluation, identification of abnormal findings, and prediction of pregnancy risk. So we have an excellent academic program ahead with expert lectures followed by an interesting clinical case discussion. So our president, Dr. Neena Malhotra, could not join us because of her busy schedule. So now I invite Dr. Shweta Gupta, Secretary General IFS, for the introduction. Dr. Shweta Gupta has been closely involved in academic initiatives of the Indian Fertility Society, and we look forward to hearing her introduction to today's program. Ma'am, over to you.
Yeah. Thank you, Bhagyashri. Uh, I think you can see me, no? You can hear me as well.
Yes, yes.
Thank
Yes,
you, ma'am.
ma'am.
So thank you, Dr. Renu, for your kind invitation. And I think this is going to be an excellent session because this is something we all need to be aware of how the things are in early pregnancy, whether she is conceived in a normal through normal way or whether it is through IUI or IVF. So very relevant, I think, the topic, and also with our initiative of Dr. Neena Madam of especially the focused webinars with the input from the right kind of related persons and the field. I think this is going to be an excellent webinar with Dr. Suhani Madam as a mentor, and she is always so thorough and systematic with all the things. So she is our mentor for this particular SIG. And we also have two chapter secretaries involved, two chapters. One is the Rajasthan and Haryana. So Dr. Urmila and Dr. Meenakshi. It's a wonderful SIG as well with Dr. Neelam as and Dr. Namita being part of it. So let's listen to them. I think it's very important our topic, how to do a normal scan and how we can get the adverse fetal outcomes predicted. So very useful topic and I think very basic topic. So thank you, Dr. Renu and Dr. Meenakshi and Dr. Urmila. So over to Madam Suhani Madam uh, for her introductory talk. Thank you, everyone. Uh, Hello, good afternoon, and this is Dr. Sohani Verma. So pleased to see such an excellent program initiated by IFS and Rajasthan chapter as well as Haryana chapter. You all indeed are doing a great job. And the first trimester ultrasound, I think we all agree that it is really a very big, very precious window of opportunity, not just for correct dating, but also for the presentation. I think that will avoid so many, I think, problems later on. And of course, all the other hormonal, biomedical parameters, what we can learn in the first trimester. And not only just to prevent the complications in first trimester, but also to help us to plan for the second and third trimester and safe delivery. So a great program. Congratulations to Dr. Renu and all entire team, and looking forward to this wonderful session.
Thank you, ma'am. Thank you, Dr. Shweta ma'am and Dr. Sohani ma'am for your valuable words. Now we'll move on to our first scientific session, early fetal anatomy assessment and abnormal placentation. Our chairpersons are Dr. Sohani Verma, Senior Consultant, Indraprastha Apollo Hospital, Sarita Vihar, and Apollo Fertility Center, Lajpat Nagar, and Dr. Namita Kotia, IVF Specialist, Cocoon Hospital, Jaipur, Dr. Urmila Sharma, Clinical Director, Ishwa IVF, Jaipur. Now I request Dr. Sohani Verma to introduce our speaker for the next session.
Okay, thank you again. It's indeed a privilege to introduce Dr. Kuldeep Singh. I think he's a very, very eminent, very well known and scholar in his own area. I know him. He has been doing a lot of work and the highest quality work. So definitely we are looking forward to your lecture and your, I think, take home message for all the audience for early fetal anatomy assessment and abnormal placentation. And you are from Noida, master trainer in the field of ultrasound, which is so passionate you are about. And I think it's there on the slide, and everybody knows you, Dr. Kuldeep. So I think unless my co-chairperson, Dr. Namita, Dr. Urmila, want to say something else, I think I'm looking forward to your talk, Dr. Kuldeep.
Yes, Dr. Kuldeep, we are eagerly waiting for your talk. Please proceed.
Thank you. Thank you so much. I'll start sharing my screen. Thank you so much. I'm going to be talking on, because I just have 20 minutes, I'm going to be talking more on the fetal anatomy assessment, because that's a very important topic and that needs to be taken care of. I hope you can all see my screen, Ji. Is my screen visible?
Yes, we can.
Yes, it is very
Perfect.
visible.
So I'm going to thank you
Yes,
so much,
yes.
Dr. Swani ma'am. Thank you, Dr. Namita. Thank you, Dr. Renu ma'am, for giving me this opportunity. I'm going to be talking on early fetal anatomy assessment, which has now become so important, because when we started with ultrasound, that was many, many, many years ago, it used to be just looking in for anencephaly and acrania, and that too at 40 weeks. And we've come quite far now, looking at plenty of these things. So we have ongoing technological advancements. We have high frequency transvaginal scanning, resolution of the ultrasound imaging in first trimester, really getting better and better. The machines are getting smarter. We need to get smarter so that we can understand the early fetal development and we can monitor that in detail. What are the advantages of seeing something, let's say in the 11 to 14 week scan, is early reassurance to at the risk mother early on, detection and exclusion of many major anomalies, earlier genetic diagnosis, and an easier pregnancy termination if need be. As we all know, the ultrasound is operator dependent, so one has to have the specific amount of experience to look in for. Then you need to be aware that there are plenty of structures that are not going to be available at that time. We are basically, let's say if it's a corpus callosal agenesis, it's a hypoplastic left heart, we'll not be able to really look in for it at this stage. So there is no point trying and making a diagnosis. Vermis hypoplasia, you'll not be able to. So you have to be aware of what structures are going to be seen at what stage. You're looking at just an eyeballing. You start off with an eyeballing, looking at the cranium, looking at the limbs, looking at the spine, looking at the heart over there, looking at the diaphragm with the lung above and the stomach below, and you've ruled out plenty of things. And then you can always go in for a detailed assessment, and I'm going to be showing you the ECOG guidelines. Then at 11 to 14 weeks, we need to first confirm the gestational age. We need to assess the chorionicity. If you've done a dating scan at 7 to 8 weeks, fair enough. You can always correlate. You could measure the nuchal translucency thickness, and I'm not going in for the genetic sonogram today. And you need to visualize the basic anatomical structures. In terms of a transvaginal scan to visualize the fetal anatomy, as the fetus grows older, 11 weeks, 12 weeks, 13 weeks, and close to 14 weeks, we are able to see on a transabdominal and a transvaginal, plenty of structures. And in terms of, if you see for the anatomic structures, you can see in terms of not ruling out an anomaly, but to visualize these structures, we've seen quite a bit. As close to 95 to 100%. The heart we need to be working more on, but again, we're getting smarter. Kidneys also, we need to be working harder on that. You're looking at just an eyeballing. See the premaxillary triangle that appears. We're looking at the heart over there, the limbs. Looking at the spine. And I'm going to be gradually showing you each and every system. Looking at the heart. And we know this is the spine, so this is the left side, this is the right side. So we have the left atrium, left ventricle, right ventricle is the anteriormost, and that's the right atrium. So you've seen plenty of a four-chamber view. You're looking at the outflow tract, you're looking at the LVOT. You take a transverse section and you're able to see that's the lung over there. Why is my voice echoing? Is somebody else's on? I don't know. It's okay. So you're looking at the chambers over there. You're looking at the connections, and that's what you need. You're looking at the diaphragm. You're looking at the stomach below and the heart above. Mukul, the voice has started echoing. I don't know why that's happening. So if you could just check that. We're looking at the spine over there. We're looking at the kidneys over there. That's the butterfly wing. That's the thalamus. And we know with such a comfortable one, we're not looking at a crash sign. We're looking at the ears over there on either side. You're looking at the ribs, you're looking at the spine. See the kidney over there, the spine, looking at the other kidney. We're looking at the chambers of the heart, all the three acidification centers, the kidneys on each side, and I'm looking at the ribs as well comfortably. So when you're trying to assess fetal anatomy, a significant proportion of structural anomalies can be detected through a detailed systematic examination. You need to examine the structures included in the protocol, which I'm going to tell you now, and you need to provide an adequate time for a detailed structural survey. So if we follow the ECOG guidelines, that's how we start off with. You need to be first doing a mid-sag view of the first trimester fetus. You're trying to look in for these structures. You're supposed to be measuring a proper crown rump length. There has to be a zoomed in image. You're supposed to be looking at the umbilical cord. And whenever in doubt, you can always take your color box to the fetal urinary bladder. And you'll be able to see both the hypogastric arteries. The moment I'm looking at a placenta which is there on the same wall, I need to figure out whether I'm looking at two placentas or one, dichorionic or monochorionic, because the prognosis matters. If I'm seeing this sort of a beak sign or a lambda sign, I know I'm looking at two placentas. And if I see a T sign, that means it's a monochorionic placentation. When you start off looking at the cranium in detail, see the skull for the completeness, looking at the choroid plexus, looking at the forks over there, and this has to be symmetrical. You're looking at, again, the ossification. You're looking at the thalamus. You're looking at the lateral ventricles over there, cerebral peduncles, and if this comes closer to the occipital bone, we're looking at a crash sign. And if you do not see, you're just looking at just a huge choroid plexus, you could be looking at a dry brain. These are the things that you're looking at. You're seeing the posterior cranial fossa now. Though you're still not supposed to be making a diagnosis of any vermis hypoplasia, but you can see these areas communicating. That's the cisterna magna, that's the fourth ventricle. Mid-side view, you're looking at That's the frontal bone, the nasal bone, the maxilla. This is an ideal time to look in for any maxillary gap. Mandible over there, and if they are in proper alignment, we've ruled out micrognathia. You're looking at the diencephalon, the brainstem. This is the fourth ventricle or the IT, the cisterna magna, occipital bone, and you're looking at the nuchal translucency. Then you're looking at the lenses over there. You're looking at both the orbits, and we know they are absolutely symmetrical. When you're seeing this portion, that's the premaxillary triangle. You're supposed to be looking at this portion, that is the alveolar ridge, and at the top of these limbs of the triangle are you looking at the nasal bone. You're supposed to be seeing the cardiac axis, and you can measure the angle. You're supposed to be looking at, is there any cardiomegaly as well? The four-chamber view, and I'm going to be showing you videos of all this. You're looking at a four-chamber view over there, and you can see the atria and the ventricle, atria and the ventricle. Towards the spine is the left side, and away from it is the right side of the heart. You're supposed to be looking at, this is the pulmonary artery, aorta. And because you haven't reduced the scale too much, that is why you're not able to see the superior vena cava. Something that we are now seeing at 20 weeks, 19 weeks, 24 weeks, we've now started seeing at our 11 to 14 week scan. Appreciate the stomach being full over there. The umbilical cord insertion we're looking at. So if you're looking at a physiological gut herniation, that is going to be there between 9 to 11 weeks. And that too also, if you find the gap in the abdominal wall is more than 7 millimeters, or the herniated contents are more than 7 millimeters, or the herniated content has liver, you know, even at that stage, it's pathological. You're supposed to be, if you're looking at an omphalocele, the umbilical cord insertion is going to be at the tip. For gastroschisis, it's going to be on the side. I'm not taking the anomalies, but letting you know whatever normal you're seeing, you'll be able to appreciate that. The two hypogastric arteries on either side of the bladder. You're looking at the pelvis over there. The fetal bladder is there. And whenever you're supposed to be measuring the fetal bladder, it has to be craniocaudal, not right to left or anterior to posterior, and up to 7 millimeters is normal. When it's 7 to 15, you're thinking of aneuploidies, and when it's more than 15 millimeters, you're thinking of an obstructive uropathy. So you've seen the bladder filling, you've seen the anterior abdominal wall in the lower portion, upper portion, and the mid portion, and it's fine. You can see both the kidneys on either side of the spine, echogenic, which is absolutely normal for this stage. Complete spine seen over there, and you're seeing the cutaneous and the subcutaneous elements. Looking at a transverse section as well, as I showed you in the beginning, and you can do a coronal view. Looking at the limbs, you see all the sections, the proximal, the mid portion, the distal. Similarly for the upper limbs, you're looking at both the elbows, both the arms, forearms, and the hands. So here you're looking at the skull for completeness, and if you've seen a skull like this, you've ruled out acrania, anencephaly, or an encephalocele. Supposed to be looking at the midline fox, a butterfly choroid plexus. Midline fox, complete skull, and a butterfly choroid plexus. Butterfly choroid plexus. That's what you're seeing in the choroid plexus. Interhemispheric fissure, the ventricles, the sylvian fissure, the frontal, and the occipital portion. This is extremely helpful when you're trying to look out or rule out open neural tube defects. That's the same section for which you see the nuchal translucency and the nasal bone. That's the nasal bone. That's the diencephalon. The medulla, the pons over there you're looking at. That's the medulla. This is the mesencephalon that you're looking. Fourth ventricle, that is the IT or the ICT, intracranial translucency, that's the cisterna magna. These three ossification centers extremely helpful. So if there is an open neural tube defect, the fourth ventricle is going to collapse. The brainstem is going to be much more bigger. This is the brainstem and the brainstem occipital distance. So if this ratio reverses, means there's a collapse of the fourth ventricle. You have to be looking at the spine to look for open neural tube defect. You're looking at the lens over there. You're looking at a profile. You're looking at both the orbits and you're looking at the sutures. Examine the orbits and the lenses. You're looking at the fontanelle and the sutures over there. These two are the nasal bone points, the zygoma, and this is the alveolar ridge, that is the triangle that is formed. So that is of utmost importance. We need to be following the dictums that the eyes are going to see what the mind knows. So if you're aware of it, look at the nasal bone, the nasal tip and the nasal skin making an equal to sign. But I need to zoom this image. And I'm looking at these three anechoic areas. This is the brainstem, the IT or the ICT, and that's the cisterna magna. And you just have to get into a habit of it. The lens over there. And the other dictum we always need to follow is, if anyone can do it, you surely can do it. Lens in the eye socket. You need to be looking at the complete alignment of the spine. That's the spine seen over there. Butterfly choroid plexus, intermetric or the midline fox, and you're looking at the spine. See the three ossification centers, two posterior and one anterior throughout. You need to go transverse and you'll be able to get the complete section. The heart, you need to be looking at whether the situs is fine or not, and there are plenty of things that you can see in the heart now. Looking at the four chambers, looking at the stomach bubble. So we know the heart and the stomach are on the same side. Now we need to be looking at, is it on the left side or not? So that is how you're going to be looking at which side is the spine, where is the head, and that's how you're going to realize. Or you can always follow the palm technique. When you're looking at the outflow tracts, that is what you need to see. The pulmonary artery, the aorta, what we call the tick sign. The four chambers. This is the left side, the right. This is the outflow tract, and we're looking at the PAS as well. The pulmonary artery, aorta, and the superior vena cava. You just have to get into a habit of it. And do not presume if I'm not able to see something means it is normal. Not at all. You need to be very watchful till you've done a complete assessment. Both the atria, both the ventricles. That's a dual live mode where you can see color on one side. You need to visualize the stomach as an anechoic or a hypoechoic structure. The stomach needs to be full. The stomach and the bladder are two dynamic structures. So don't worry if you're not able to see it once. Hold on. Do the complete other survey. Umbilical cord insertion. We need to be visualizing the kidneys. Transverse section, you can see both the kidneys, otherwise see for each of them. The bladder needs to be filled, and we need to be measuring it craniocaudal, and up to 7 millimeters is normal. You need to be examining the long bones, the fingers, toes, and you need to be looking at movements. In fact, this is the best time where you would be able to look in at all the sections of the limbs. So see them very carefully. Both the feet over there. We're looking at the femur, the tibia and the fibula, both the knees. And similarly, you need to be visualizing the upper limbs as well. You can see the fingers. You can see the foot. So in terms of screening for anomalies in the first trimester, we're getting better and better. We're getting smarter and smarter. Whatever the overall diagnosis we were able to do at 11 to 14, we are now getting better. This is an old chart, but now things are much more comfortable. Just 2-3 slides now on what are the anomalies we should not be missing. The always detectable 9 anomalies: exomphalos, encephalocele, megacystis, missing limbs, acrania, alobar holoprosencephaly, encephaly, body stock anomaly, and gastroschisis. So with non-invasive prenatal testing entering the paradigm of aneuploidy screening, the role of first trimester sonography is changing. So we now gradually, we get an NIPT done. We are going to be looking at the NT for a few more years, but we're now focusing much more on the structural assessment. So we're getting a much better opportunity. Machines are really getting better and better, and we can identify plenty of structural anomalies, which is now a standard practice, which we all are adopting. Thank you. Thank you so much.
Thank you, sir, for that comprehensive and the insightful presentation. We now have 10 minutes for discussion.
So, any questions?
You can see in
And
the
every
chat
like
box,
we have 10
Namita.
minutes. I would have added
No,
a few
there
more
are no
slides.
questions. Presently, no. Dr. Kuldeep, I would like to ask you regarding the abnormal placentation at this gestational age. So,
See,
what
the
about
thing
the
is, when you're looking at, you're going to be always looking at, in terms of first the position, whether is it low or not, depending on, and usually at this stage, all the placentas are low. What you really need to be looking at is where is the umbilical cord inserting, how are the margins of the placenta. Are we looking at circumvallate, circummarginate? Are we looking at a battledore placenta? So all those things, again, once we have an index of suspicion, we're going to be looking at those things in detail. In terms of previous, rather than mentioning it, we now mention the exact distance. Is it up to the internal os? Is it covering it? And how far away is it? We've now started gradually looking in for any sort of an accreta, though this is quite early for that, but we always like to look at the retroplacental space for sure. If it's an anterior placenta, previous cesarean, I'm going to be seeing the retroplacental area in much more greater detail, even at this stage.
and anything regarding the PI and RI of the uterine vessels at this stage?
See, absolutely. I didn't cover that up, the screening portion, but we are supposed to be looking at, earlier on it was, should we do the placental side, non-placental side? But then we realized it that we need to be doing the right main uterine artery, left main uterine artery, taking out the pulsatility index and taking a mean. Now, again, the cheat code in this is because there are plenty of messages that I keep on getting is why am I getting a reversal of flow? There is no reversal of flow. It is just that we are insonating the iliac flow. Then why is the patient having that? When I see the pictures, the resistive index or the PI was normal. The thing is, might be we've insonated the radial artery. You need to be insonating the main uterine artery, and for that you need to be taking the scale or the velocity or the PRF to a little higher level. So you need to be taking your scale to 30 to 40 centimeters per second. Once that is there, now you're not going to be seeing the radial and the spiral. The only two vessels that you're going to see is uterine artery and iliac. You want me to show you the waveform? I can do that, ma'am. Do you want me to share it and show it to you, ma'am?
If we have time, Dr. Renu, we have time, can we?
We will
Yes,
be
ma'am, we have.
I think we are nearly through with the time.
Okay.
And
So we have one last question from Dr. Natasha. From which gestation is placental anatomy well visualized as well as the cord? What
See,
is the
the thing
exact
is,
gestation?
we earlier were doing it much more in the anomaly scan. But now we've started doing it in the 11 to 14 because the machines are getting much better. Look at the amount when we're doing our harmonics, when we are increasing our grayscale and dynamic range, we're getting a much more smoother image, a much more clear cleavage of where exactly is the placenta. So you can start seeing now from your 12 to 14 week scan as well.
Thank you so
And
much,
umbilical
Dr.
cord, for sure, you need to be looking at the two hypogastric arteries so that if there is a single umbilical artery and I'm looking at a thick nuchal translucency, I need to be making sure that I'm not missing out on any stuff.
So thank you, Dr. Kuldeep, for such an
Thank you.
informative session. So now we can proceed to the next session.
Thank you. Thanks to our chairpersons and Dr. Kuldeep Singh sir for a very enriching discussion. Now we'll move on to a second scientific session. The value of early ultrasound extends beyond identifying abnormalities. And the next important question is, can findings in early pregnancy help us predict which pregnancies are likely to have adverse outcomes? This brings us to the concept of early risk stratification and personalized antenatal surveillance. So the next lecture will be on predicting adverse fetal outcomes and its clinical application. I invite our chairpersons, Dr. Neeti Tiwari, co-director, Center of IVF and Human Reproduction, Sir Gangaram Hospital, Dr. Bindu Bajaj, professor and HOD of Obs and Gynae Department, VMCC and Safdarjung Hospital, and Dr. Meenakshi Dua. I request Dr. Bindu Bajaj ma'am to introduce our speaker for the next session.
Mukul, can you unmute Mr. Bindu? Hello, Mukul. Please unmute
Ma'am,
Dr. Bindu.
Yes, ma'am. Yes, ma'am.
Dr. Bindu, are you there?
Yes, I'm there.
Okay.
So, hello everyone. So, the next session, I'll be inviting Dr. Neha Varun, who's Associate Professor in AIMS Delhi, and she has multiple awards to her credit. She has had Kamini Rao Oration Award in 2022 and Vidya Bhasin Award 2024. And I think within a span of 3 years, she has had 4 awards and more than 100 publications and various chapters in the book. So welcome Dr. Neha Varun. She'll be speaking on predicting adverse fetal outcomes and its clinical implications.
Thank you, ma'am. I like to thanks Neena ma'am, Shweta ma'am, Sohani ma'am, and especially Renu ma'am for inviting me here. It is always a pleasure speaking in front of your teachers who taught you everything. Thank you, ma'am. I'm just sharing my slide, ma'am. Just let me know if it is there. Is it visible, ma'am?
Yes.
Okay.
Can you do it full screen, Neha?
Yes, ma'am. Yes, ma'am. Is it okay now?
Yeah.
Okay. So, as we have already discussed a little bit about this, so I will be mainly concentrating on how we can predict the adverse fetal outcome, and we'll discuss a little bit about its clinical application. Mainly, I'm limiting to the first trimester ultrasound. So this is just a gist how we are going to go about. So we'll just go through the first trimester ultrasound checklist, going to NT, uterine artery Doppler, the roles of cervical length measurement, predicting preterm preeclampsia. First trimester anatomy has been discussed in detail, and clinical prediction workflow. So the first and the foremost message what I want to give, which we are telling in since we have started this webinar, the first trimester ultrasound is no longer only a dating and aneuploidy scan. It is an opportunity to identify the pregnancy phenotype and predict complications before they become clinically apparent. So, like, why does the first trimester matter? It is actually an opportunity. The first and foremost, we look at the placentation, as somebody has already asked, that abnormal placentation. It can precede clinical preeclampsia and the fetal growth restriction by months. Early signals, which leads to ultrasound, reveals fetal, placental, and the vascular markers. And definitely, whatever we are getting as a risk prediction, Until unless we have an action, they doesn't matter. So by predicting all these things, we have a risk stratification which can guide prevention and the surveillance. So think of 11 to 14 week scan as a risk map and not just a dating scan. So we can look at the prediction of preeclampsia, fetal growth restriction, aneuploidies, structural anomalies, pregnancy losses and selected placental disorders, and a preterm birth risk. So earlier prediction, we have a earlier intervention. So what all we can measure with the first trimester ultrasound? So first is a fetal biometry, which includes the CRL, biparietal diameter, head circumference at the femur length. Then we have aneuploidy markers, which include the NT, nasal bone, ductus venosus, and the tricuspid regurgitation. Then early anatomy has been discussed in detail by Dr. Kuldeep sir very beautifully, that what all we can detect in the first trimester: brain, face, heart, abdomen, limbs. And then we have the placenta and the Doppler indices, in which we measure the uterine artery PI. So the best predictive value of any of these, it comes from the combination. So we should always have a maternal factors, mean arterial pressure, ultrasound markers, and there are certain biomarkers we are going to discuss to predict any type of the risk in the patients. So coming to the nuchal translucency, it is a risk marker and not a diagnosis. So increased NT, it suggests aneuploidy risk, and we all know that increased risk is associated with trisomy 21, 18, 13, and Turner's. There are certain congenital heart disease and the structural anomalies are there. And then we have the genetic syndrome, which can occur even with a normal karyotype. So when we are getting these marker as an increased risk, so that it guides us for the genetic counseling, and plus the appropriate diagnostic and the screening pathways should be in place. So the 11 to 14 week ultrasound, we have to look beyond NT, and that is systematic assessment rather than the nuchal translucency alone. So coming to beyond NT, this I have summarized in one slide. I'm not going into the details how we are going to do, but yes, we all know that a nasal bone is an important additional first trimester marker for the aneuploidy. Tricuspid regurgitation, again, one of the important second line ultrasound markers at 11 to 13 plus 6 weeks, particularly when assessing the risk of chromosomal abnormalities and the congenital heart disease. Coming to the ductus venosus, it is one of the most useful additional first trimester marker beyond NT, particularly again assessing the risk of chromosomal abnormalities and the congenital heart disease. So any of these like abnormal TR and ductus venosus and nasal bone abnormality, they are all a risk marker and not a diagnosis. And then we have a first trimester systematic and the detailed anatomy, and the other markers are also there. So coming to the first trimester anatomy, which is another layer of the risk prediction. So we have major CNS, face, thoracic, cardiac, abdominal, and the limb abnormalities. Then we have a systematic ICOG protocol, which improves the detection rate. And early abnormality leads to early counseling and the targeted genetic evaluation. And definitely, if at all patient is requiring MTP, we are in that window. First trimester ultrasound, it doesn't replaces 18 to 20 week anatomy scan. So recently ACOG has released its updated detailed fetal anatomy ultrasound in the first trimester. So now coming to a very important other marker. So coming to uterine artery Doppler, it is giving us an early placental window. So increased uterine artery PI, which is usually more than 95th centile, it is the result of the increased uteroplacental resistance. So abnormal presentation leading to placental dysfunction, and that we can have a prediction for preeclampsia and the fetal growth restriction. But again, I said in the beginning, do not interpret uterine artery PI in isolation. Its value rises in a combined screening model. So we are not using any of these markers alone. We are putting in the combination screening models. So just quickly, tips and tricks for measuring the uterine artery PI. So we have to have a correct site. So which means clearly a true mid-sagittal view of the uterus and cervix, and you have to identify the cervical canal and the internal cervical os. When we have identified this view, then you have to rotate your probe to the right and the left, and we have to sample the correct vessel. And this is the most common pitfall when we are measuring the uterine artery. So don't accidentally sample the arcuate artery. So how we can ensure that if you are looking at the peak systolic velocity in the uterine artery, it is more than 60 centimeters per second. If it is less than that, then you should check your ultrasound that whether you are picking the right artery or not. Angle of inclination should be less than 30 degree and should be as close to 0 degree as possible. Use a small sample gate 2 mm, because if you use a small sample gate, it will sample only your uterine artery and it will not include the nearby vessels. Whenever we are measuring a uterine artery PI, we have to have a 3 identical waveform. So you should not take just one you are measuring and taking it as a PI. And we have to measure both bilateral, which is right and left, and then you have to calculate the mean PI from right and left. Usually we are not using the fixed cutoffs of the uterine artery PI. We are using the multiple of medians, and you have to put it in the combined FMF risk. So as such, if you look at the cutoffs, they are actually vary according to the technique you are using, like the transabdominal or the transvaginal. They vary according to the gestation you are measuring. So we always use multiple of medians and PI if it is more than 95th centile. So now coming to the third marker, which is the cervical length. Again, it is an early window on the preterm birth, and it is to be when we are measuring it in 11 to 13 plus 6 weeks. Again, we have to measure the endocervical canal. I will be telling in detail in the next slide how we are going to measure. But we have to know that the shorter first trimester cervical length is associated with higher preterm birth risk. According to the ICOG, women who deliver preterm tend to have a shorter cervix in the first trimester. First trimester cervical length, it may add information to personal history and other risk factor. But yes, very important to know here that the first trimester cervical length is not yet an established universal screening test. And we should not automatically apply the usual mid-trimester short cervix threshold to 11 to 14 weeks. So mid-trimester transvaginal ultrasound cervical length remains the established clinical screening approach. So the important thing which I have told that it is a promising predictor, but yes, it is not yet a routine standalone intervention trigger. Now, what are the tips and tricks for the cervical length measurement? So, as I have already told that it is a potential risk marker, but not universally accepted cutoffs. We don't have any universally accepted cutoffs for the routine screening. So, in transabdominal and the transvaginal, we prefer a transvaginal sonography. We'll ask the patient to empty bladder. Again, a true mid-sagittal plane is required. We have to identify both the osses along with the endocervical canal. We have to apply, this is a very important practical point, we have to apply minimal pressure, because what happens when you have an excessive pressure, it can elongate the apparent cervix and close the internal os and ultimately alter the appearance of your funneling. And then magnify the image. You should aim for approximately 75% of the image. So basically your cervix should, it should include 2/3 of your screen. Then you have to place the calipers correctly. So do not measure the straight line distance if the cervical canal is curved. Don't mistake the lower uterine segment for the cervix, which usually happens in the first trimester. And then it is very important that you should have a dynamic observation, because observe the cervix for at least 3 to 5 minutes, because what happens, sometimes there is a funneling, sometimes there is a shortening, sometimes the internal os opens. So you should observe it for at least 3 to 5 minutes. Then again, we have to take more than equal to 3 measurements, and you should record the shortest technical correct measurement. And we have to measure the closed portion of the cervix from the internal os to the external os. So very important, do not measure the funneling. It is only the portion from internal to external os. So one thing I want to just reiterate here, that I have told that we have to measure the straight line distance. But in wherever we see like SIOG and the MFM models, they say clinically it is actually not that much applicable, because if you have a short cervix, it usually becomes straight. But yes, we should know that we have to measure it like a, whatever canal is there, we have to measure it like, not just like a internal os to external. So there is one systemic meta-analysis recently published in 2025 on the first trimester cervical length screening and the risk of preterm birth. They have included 5 studies which comprise 16,053 pregnancies, and they have included all the studies where they have measured the cervical length in the first trimester and the patients who had the preterm birth. So they have seen that the first trimester cervical length is significantly associated with the preterm birth risk, but again, its clinical utility as a predictive tool, it remains uncertain. So now coming to the third very, very important thing, predicting the preterm preeclampsia. Again, this is the combined model. So this preterm preeclampsia, it includes the parameters, which includes maternal history, which includes demography, obstetric, and the medical history of the patient, mean arterial pressure, uterine artery PI, the biomarkers, which include the PLGF, and on the basis of this, we calculate the risk of the preterm preeclampsia. So why we combine all these factors and we are not taking any individual factor like the uterine artery PI? Because it captures a very important risk factor, which is the maternal baseline risk for that particular risk. It reflects the current hemodynamic state of the patient. It adds placental resistance plus angiogenic signal, and it is better than any single surrogate marker. So when you combine all these risks, the risk of preeclampsia less than 37, less than 34, and very important, preterm preeclampsia is very, very important. So whenever you identify a woman who may benefit from the preventive strategy, you again definitely we all increase our surveillance and we have the preventive measure. So this is, I have just given a commonly used MFM risk prediction model. What we have, the calculators are available on the FMF website. So when you put all these factors for the FMF approach, a commonly used screen positive threshold is more than or equal to 1:100 for the preterm preeclampsia. So if the patient is screen positive, we should consider a preventive aspirin according to the applicable protocols. So now coming to third, which is the placental dysfunction. So a question, can we predict FGR before the fetus becomes small? Yes, because if the placenta is having a decreased placental function or a placental dysfunction, it leads to increased uterine artery PI, decrease in the PLGF and the PAPA levels, and leading to abnormal placental indices, and which can predict the FGR or the SGRS. So all these early markers, they are imperfect, but multivariable models are more promising. And we have recently there was a 2024 prospective work is also there, which have explored the placental biophysical models. So these all are still evolving, but definitely not a standalone diagnostic test. So now from ultrasound finding to the clinical decision. So we did a scan, we measured the CRL, we measured NT, fetal anomaly, and the uterine artery PI, and we integrate all these models into the maternal history, mean arterial pressure, and all those biomarkers which include PLGF and the PAPA. We estimated and predicted the risk for aneuploidy, preeclampsia, FGR, and other selected outcomes. And then it's an important point that you have to counsel, you have to prevent, you have to do the surveillance. And if at all you are in a smaller center, you can always refer the patient to the higher centers for the better surveillance and the monitoring. So the value of prediction is realized only when it changes the care. So finally, to summarize, the first trimester is a window into the future risk. Ultrasound is more than a dating. So NT plus early anatomy leading to fetal and the anomaly risk. Uterine artery PI gives us the placental resistance. Combined model, maternal factors, MAP, uterine artery PI and PLGF gives us the stronger preeclampsia prediction and the preventive measures. And we use prediction to trigger prevention, counseling and surveillance. So predict early, act early and individualize care. Thank you.
Thank you, Dr. Neha Varun, for that excellent presentation. We now open the floor for discussion.
One thing what I feel that apart from the fetal anatomy, what we have discussed, but like uterine artery PI, cervical length measurement, it is not, restricted to the fetal medicine specialist. So this is the thing which we all can do if we are performing an ultrasound, and that gives us very, prediction for the very important medical disorders.
Very, very elaborate talk, Dr. Neha. Really enjoyed listening to you. I have one question that, when you find a short cervical length at that 11, so I had patient who had 2 centimeter of cervical length. Do you advise a early scan before the second trimester,
So,
the routine 22
so
weeks, 22 weeks?
So that's why I have gone into the literature, and definitely we all are practicing also. Routinely, we are not doing the cervical and management measurement in the first trimester. But yes, if you are looking at the maternal factors and if you are finding any high risk factor, then it is a very good option to do a cervical and measurement in the first trimester. Again, it is very difficult because you don't have the cutoffs. Like if you have a 25
Yeah,
the second trimester, you can't just say that less than 25 is, for the first trimester. So we can always use chart, but what I feel, if at all you are feeling, looking at the maternal factors, her history, previous obstetric history, then we should always go for this first trimester measurement, and then we can act accordingly. But
do
it
you
is not
advise do you
really
advise
recommended.
early and early scans in your practice, before the usual? So
So, so
when
the
do you do that?
early anomaly scan, what we have discussed, Dr. Kuldeep has beautifully shown us that definitely that window is 11 to 13 plus 6. But you have some like CNS, we all have been reading, that can be detected as early as 9 weeks. But, as you go earlier in the gestation and, the systems which you scan, the percentages and sensitivity is decreasing. Like even if you are doing at 11 to 13 plus 6 weeks, what Dr. Kuldeep has also shown that the heart, it is somewhere around 40-50% only. So if
Yeah.
you're doing a scan before 11 weeks, then you are again you are CNS anomalies. It is like anencephaly and all that are very good window. As early as 9 weeks you can detect, but at 9 weeks you cannot say that you have completed your systematic fetal anatomy survey. That has to be done if
Hmm.
you're doing, like ICOG is also saying that the window is 11 to 13 plus 6. So not early we are advising anatomical assessment if you want to do it a complete systematic anatomic survey. I
Yeah, thank
if
you.
Kuldeep sir is there, he can also suggest. Sir is here. No, I think
Neha,
he's.
I also
The
wanted to
only
ask.
problem is, sorry, ma'am.
Oh, sir, please go
So
ahead, sir. Sir, please go ahead.
The only problem is these machines are getting so fantastic that normal structures like a rhombencephalon, or when we're looking at three cystic cavities, and I get a picture on the WhatsApp, sir, I've diagnosed hydrocephalus even at 8.5 weeks. So we need to be really little wary of that also. That there's so many normal physiological things happening, and there's a particular time to make a diagnosis, not very, very early.
Yeah, that is very important, sir. Unnecessary, concern it causes for patient as well as the obstetricians when they
True.
come up with these reports.
yeah, until unless we are in that window that we can report, confidently that this is the complete survey and we are reporting this, which is according to the guidelines. I think it is not good to tell anything to the patient or doing, because unnecessarily the patients become anxious. And, we are also not in a very good picture to tell everything about all the systems, basically.
So, Neha, I wanted to ask you one thing regarding the cervical length you said. So, when there is a funneling, you said you have to measure from the internal loss to the external loss. But if there is a funneling, the internal loss opens,
Yes, yes.
it widens. So, then exactly we cannot measure that. It is the internal loss diameter that has to be measured then, and
So
rather than the internal to external loss.
there are two things. So one is a funneling, and one is with the funneling, again, you are seeing a dilated internal loss also. So what the guidelines recommend, if you are having a funneling and you want to measure that cervical length, then you have to measure the closed portion. So that is actually giving you the remaining cervical length. So
Yeah.
if you want to document cervical length, that is the closed portion you have to measure, excluding funneling. But definitely you will
Yeah.
report that funneling with the closed cervical length of whatever 2 centimeters.
Hmm. It is the remaining cervical length which is there.
Yes,
Remaining
yes.
cervical length, the closed
Yeah.
cervical.
Dr.
Secondly,
Neha.
I wanted to know, you have read that systematic review in that cervical length. No, what was the cervical length of those people? They
So,
had
ma'am,
predicted preterm
what they
in
have
the
done,
first trimester.
yes. So, according to the gestation, they said it varies. So we don't have a cutoff, but it varies between 2 to 2.5. Majority of the cases, those have increased chances of the preterm birth. But again, they themselves has given the limitations that the studies are not, like, they are not all randomized trials. There is a heterogeneity of the this thing. So universally we are not recommending, but yes, it is between 2 to 20, I mean 20 to 25 cervical length.
So, Dr. Kuldeep sir, I wanted to ask you one thing. I wanted to know regarding when you do a scan for first trimester and when you do the cervical length, what is your cutoff? When will you tell the patient now you have to get worried or something like? Is there any cutoff for you?
See, that is basically less than 2.5 centimeters when
Yeah.
I show a bit of a concern. More than that, even if it is 26 millimeters, 27, I know it's going to get better and we don't need to be raising an alarm button.
So I think that everybody takes 2.5 the cutoff.
Yes.
That is
Yes.
what I just want to tell everybody because that
But what about twins, Dr. Renu? What about twins? I mean, we have had IVF pregnancies, we are losing them, and the cervical length was pretty decent, है ना? तो उसमें आपका क्या experience है? You feel that it is enough 2.5
Yeah,
centimeter?
Dr. Bindu, I'm usually taking that 2.5. If it is 2.5, I'm happy. See, on basis of short cervical length, and there's no history of prior preterm. So for me, a history of prior preterm birth is very important. Anything like she has a miscarriage around 16 or very short, quick, painless, causeless bleeding.
IVF
So
pregnancy is the first pregnancy that she is
no,
having.
that's okay. That for that patient, I'm going to take 2.5 as the cut.
2.5 only. I think 2.5 only, Dr.
I'm not going
Bindu.
to, not.
And twins is one area where putting a cervical stitch is also like a double-edged sword.
We have
So
not
one
been
has to.
putting. We have not been putting
Oh,
the
no,
stitch, but
even we don't put.
we have lost
People do
babies.
randomly put the stitches, but we are not putting at all. It's not
Yeah.
required. We are doing the assessment. We are doing it 20 weeks again. Then we are more vigilant for these kind of patients. Again, you can see somewhere between 26 to 28 weeks or 24 weeks if you are so vigilant. And if you think this shortening, maybe you can add progesterone support. That is what we are doing routinely. We are
Yeah,
not
we are
putting a
also.
stitch.
The point is,
And
some of them patients just sail through with everything, and the other patients, some of them just lose. That is their first baby only IVF pregnancy. So that
But
is
then
what
you
may
have to be
concern.
very clear about the infection. They should not have any type of infection anywhere. We always say it is because of the cervical incontinence. It could be because of the infection leading to preterm birth.
Yeah, that is very important to look for infection because sometimes it has happened that the patient had history of preterm birth and then somebody put a stitch for them, still they aborted. And when they come to us, then we are in a dilemma what to do because they aborted without stitch, they aborted with stitch. So the best thing for them is to probably look for infection and and extensively and treat them and then give a good progesterone support.
So,
And
Neeti,
always
what
do
I
a
decide,
TVS for the cervix, ma'am. Always do a TVS because a
yeah.
transabdominal and an overfilled bladder will always show as if there's a funneling, and you'll find a long cervix, which could be wrong also because of the compression of the bladder. So it has to be
Yeah,
a transvaginal scan.
Okay,
that
thank
is
you.
very important. Yes, sir.
Neeti, can you just see the questions and see for this session so that Neha can answer them? I think we have a lot of questions in the chat box.
There was one question where it says, does a short cervical length causes preeclampsia or is it merely an incidental finding?
Neha, would you like to answer that?
There is no correlation
There is no correlation, Haryana, I think.
with eclampsia.
And there is one more question. Do we need the FMF certification for reporting the scan?
So, not exactly the FMF certification, but I think Dr. Kuldeep can answer better. But what I feel that if you are
अभी
a
आज तो लेना है इको स्प्रिंग भी लेना है फिर कल
Amita, can you unmute yourself, please?
सॉरी
So, if you are asking me about cervical length and the uterine artery, then I don't think we need a FMF certification or any kind of the fetal medicine specialist fellowship or degree. But yes, if you are reporting on NT, DV, TR, then you should be. Sir, can you
See,
comment?
it's always a good idea to send those 3 pictures, and then that really makes life easier. So you know you're doing the right thing. So it's like a very mini test being given. But the only other thing is nowadays we have such software, and they come and give you the software and they install it on your laptop. So you can do all those calculations even if you buy that software also. But an FMF certification basically means yes, you've done a good job and you're clear about it.
Okay.
So, one question I would like to ask that in patients who have recurrent preterm labor and despite os tightening or McDonald's suturing, what is your cutoff length of the cervix for interval pregnancy laparoscopic encerclage?
I think if your patient is having the recurrent preterm births, then you can very well go for the interval, this thing, cerclage. If there is a history, that's a historical base, and it is always good to have an interval laparoscopic cerclage rather than having a McDonald's or, the failed cerclage or the shit.
Because sometimes patients in the interval period have a cervical length of 3.2 centimeters. And the moment they start approaching to 11 to 12 weeks, the length suddenly shortens. So in that case also, I think with a significant past history, we should recommend laparoscopic interval encerclage.
Yes, historical based is always, and it is always good to have a interval cerclage.
Okay. Thank you.
Thank you.
Bhagya, can you
Thanks.
take?
Yes, ma'am. Thanks to all our chairpersons and our speaker and all the participants.
Thank you, Dr. Renu, for the opportunity. Thank you.
Thanks, Niti.
We now come to what promises to be the most interactive part of today's program. So, panel discussion on interesting clinical cases in early pregnancy. So, this session will allow us to move through the entire clinical pathway, like clinical history, ultrasound findings, interpretation, differential diagnosis, risk assessment, counseling, and further management. So, our experts for this session are Dr. Suhani Verma, Dr. Survin Gumman Sindhu, Senior Director and Head IVF and Reproductive Medicine Center Max Group of Multispecialty Hospitals, Delhi and Gurgaon. And our moderators for the session are Dr. Renu Tanwar, Director Professor and IVF Coordinator, Loknayak Jaiprakash Hospital, New Delhi. Dr. Neelam Bapna, Consultant Obs and Gynae, Shivani Fertility Center and IVF Center, Saket Hospital, Jaipur. Now I request our moderators to introduce our panelists. Ma'am, kindly take over.
Neelam, can you do the introduction part of the panelist, please? You can start, Neelam.
Yes, yes. So can you put the slides? See the slides? Yeah, Dr. Shalu Gupta, she is the clinical director of Cloud9 Hospital, GTN.
Good evening, everyone.
Welcome, Dr. Shalu. Is she there?
Yes, ma'am.
Yes. Next, please. Dr. Natasha Gupta, she is Director Core Fertility Center, Jirakpur, and she is also the Joint Secretary, IFS Haryana. Dr. Natasha?
She was there. She
Next,
was there.
please.
Natasha, can you unmute yourself?
Yeah. Change the slide, please. Dr. Parul Garg. Yes, hi, Parul.
Hi, Dr. Neelam.
Yeah,
Hi,
long time. Yeah.
Yeah.
So she's the head of the Department of Reproductive Medicine, Artemis Hospital, Gurgaon. Next, please. Dr. Sugandha. Hi, Dr. Sugandha. She is the director of Kamla Nagar Hospital, Jodhpur, and she's doing endoscopy as well as IVF. Next, please. Dr. Juhi Bharti, she is the additional professor, Department of Obstetrics and Gynecology, AIMS, New Delhi, and she is the co-convener, SIG Ultrasound and Joint Secretary, AOGD. Welcome, Dr. Juhi.
Thank
Dr.
you.
Richa Sharma, she is the director, professor and unit head, OBGYN, UCMS and GTB Hospital, Delhi.
Richa, are you there? Yeah. She there?
But I'm not able to unmute.
Achha, I told Mukul.
Yes, I am there. Thank you. Something is happening, I think, with connectivity.
That's so.
And this.
Mukul, can you just check?
Yes, I am here. Thank you, Dr. Renu.
Hi, Richa. So, Neelam, are we through with all the panelists?
Yes.
I think Sasha is there, no? And where is Surveen? I think there's a message
I
from
think she is unable to
unmute. Mukul, can you help Surveen?
Yes, ma'am. Yes, ma'am.
Please see who are being unmuted, no?
Ma'am, try.
Hi, Surveen, you have joined?
Yeah.
Hello, welcome, Surveen.
Thank you for the invitation.
So you will be the expert and telling us all this thing. and just monitoring our panel right there. Yeah. So Neelam, you can start with the first case. Survi, should we start the first case?
Yeah, absolutely. Dr. Suhani is joined?
I think ma'am just said she was busy with some OPD. She had joined for the first session, but then she said she had to leave for some.
Okay.
Dr. Renu, I think there is some problem in sharing my screen.
Acha, okay, just then. Mukul?
Yes, ma'am.
Can you help Neelam with this thing? Neelam, have you opened your presentation?
Yeah.
Can you see the share part in the lower part? Can you see the share?
Yeah, I'm seeing the share part.
मैम उस पर क्लिक कीजिए.
हाँ.
शेयर का ऑप्शन आ रहा होगा मैम बैकग्राउंड में जो आपका.
हाँ, शेयर के ऑप्शन से तो मैं कर रही हूँ पर इससे आ नहीं रहा है.
हाँ, पहले उसको सेलेक्ट कीजिए जो आपका बैकग्राउंड पे.
हाँ.
उसको सेलेक्ट करके नीचे शेयर के बटन पर क्लिक कीजिए.
Yeah, it is there now. It started sharing. Neelam?
हाँ जी.
हाँ. Double click to enter full screen mode. He is writing over there. Mukul, help करिए.
मैम डबल टैप करिए इस पे.
नीलम डबल टैप कर दीजिए.
हाँ जी. आ रहा है अब?
नहीं
आ रहा.
स्टार्टेड स्क्रीन शेयरिंग लिखा आ रहा है बट हाँ
आ गया.
तो okay. So now we can start, but now I am not able to see the hello.
Yes, Neelam.
Yes. So okay. So this is this is about ultrasound in early pregnancy. So we have three cases. Why the first trimester scan is the foundation of modern obstetric care, we all know now because we have two amazing lecture sessions from Dr. Kuldeep and Dr. Neha. So now we'll proceed further. Why it matters important is because it confirms the location and viability. It helps in dating the dates accurately. It helps in deciding the co-unicity and anomaly screening during the early pregnancy. Also, we know now that it helps us in risk prediction, guides the management, whether we need to give some prophylaxis, and also it enables the standardized care. So now coming to the first case, a 28-year-old woman conceived naturally and presents at 6 weeks 2 days with mild spotting. Her cycles are regular and her LMP is reliable. The ultrasound findings are that gestational sac diameter is 20 mm, yolk sac is present, but no embryo is identified, no adnexal abnormality was seen, and there was no significant free fluid. So the question is open to all. Now, looking to this case scenario, she has come to you with spotting and 6 weeks 2 days. What would you do? Would you diagnose missed miscarriage, or you will repeat beta SIG after 48 hours, or repeat ultrasound after an appropriate interval, or you offer evacuation?
See. Can I speak for this answer? Can I give the answer?
Okay, Dr. Neelam.
So,
Okay, Dr. Shalu can.
So the diagnosis, the guideline says when we are doing a TVS scan, the size of the gestational sac should be more than 25 mm to diagnose as a missed miscarriage if this is the finding. In this patient, it is only 20 mm. So we will wait for a week and then call her again for the scanning. So in the repeat beta HCG will not be helpful because we are already able to see a sac and it will not give us much information. So in this patient, the answer will be C, that we'll repeat our ultrasound after appropriate interval, that is more likely we go for 7 days. So the guideline says the gestational sac should be more than either 25 mm on TVS, or it should be more, the CRL should be more than 7 mm before we diagnose a miscarriage here.
Okay, right.
That is
So,
from the TVS, yeah.
yes, yes. So this does not meet the diagnostic criteria for miscarriage. And other question is at what, yes, you have already told this, what MSD and at what CRL would you feel confident diagnosing?
मैम किसी का दो माइक खुले हुए हैं.
CR,
So the
CRL
latest
is
ultrasound criteria
the
according
CRL.
to,
Can I answer this?
yes, yes, yes.
Yeah, yeah. The answer is here only.
So the findings diagnostic of early pregnancy loss. So this, yeah. So as already told, CRL should be more than or equal to 7 mm to report an embryonic increase. MST should be more than or equal to 25 mm and no embryo. Absence of an embryo with cardiac activity at more than or equal to 2 weeks after a scan that showed a gestational sac without a yolk sac. Absence of an embryo with cardiac activity more than or equal to 11 days after a scan that showed a gestational sac with the yolk sac. And no cardiac activity at gestational age of more than or equal to 11 weeks. And the findings which are concerning but not diagnostic of early pregnancy loss are CRL less than 7 mm, MST 16 to 14 mm, and no embryo. So these are all criteria which were given by ultrasound on SRU committee on in 2024. So all these findings, they may be concerning that she may ultimately go in miscarriage, but they do not confirm that this will be early pregnancy loss. So these are the criteria by lexicon SRU's first trimester ultrasound lexicon, and these are the concerning for early pregnancy loss, and these are diagnostic of early pregnancy loss. So ISOG also says that it is very important to not to do harm, or it is very important not to misdiagnose miscarriage, because it is unacceptable. It may lead to inadvertent termination of a viable pregnancy. So these are the same criteria which we have already done. And most of the current professional bodies have aligned with this threshold since 2013. So now next question is, should beta SCG influence the decision at this stage? What is the role and limitation of beta SCG? Would you like to go for beta SCG in this particular patient?
So
in this patient,
yes.
can I speak?
Yes, yes.
In this patient, since already the GSAC and the yolk sac is visible, so there is no benefit of doing a beta HCG. Beta HCG should be done when we are suspecting any ectopic pregnancies, and the limitation of beta HCG is that if we don't find any doubling, then it doesn't mean that it is not a viable fetus.
Yes. So it is only have a role when we do not know the finding. We do not know whether it is situated in the uterus or it is the pregnancy of unknown location. The question here is the viability is there or not. So when we do not know, when we know that it is intrauterine pregnancy, then it is not needed to do beta HCG all the time, because it has its limitations. There is considerable overlap between viable and non-viable pregnancies. A single value of beta HCG cannot diagnose miscarriage, and even if we do serial changes, it should not override appropriately performed ultrasound findings. And also, the ultrasound evaluation is more directly informative once an intrauterine pregnancy has been established. So now this patient has come to you with these sonography findings. So how would you counsel this patient? Whether you will reassure or you will alarm her that you may end up in a miscarriage, because the viability is uncertain. How will you counsel?
Neelam, you can tell any of the panelists to call. I think then there's a confusion. You can just call any of the panelists, they can answer.
Dr. Juhi, yeah, you can take the question.
Yes. So,
So definitely there is nothing to raise the alarm. So unwarranted alarm, definitely it should not be there, because it is still of uncertain viability. So we have to reassure, but we have to be very clear and inform properly that these are the options. Sometimes the pregnancy, the gestational age doesn't correlate with the LMP, and the period of gestation can there can be delayed conception and can delayed appearance of fetal heartbeat. But yes, the final conclusive diagnosis can only be made after repeat ultrasound. So we have to just inform patient the correct facts, but
Yeah,
definitely
definitely.
not alarm. Yes.
Definitely. In writing the report, also, one should write the pregnancy of uncertain viability as compared to early pregnancy loss or non viable pregnancy. This 2024 SRU Multi Society Lexicon also retired the ambiguous legacy terms like blighted ovum, missed abortion, pseudosec in favor of precise descriptive terms like anembryonic pregnancy, embryonic fetal device, or intracavity fluid. So, reporting is also again very important. How should we report? Now, after reporting and advising and counseling and everything, what treatment would you advise to this women besides folic acid? So, uh, Dr. Sugandha, you can tell.
Sugandha, you have to unmute yourself. Sugandha, I think she's muted. Parul, you can.
Yeah, I can answer. Besides from folic acid, we have to see whether she has optimized the health. Like we have to see the anemia, thyroid. If she is having a thyroid disease, then we have to add a thyronorm. We have to increase the dose of thyronorm. Then we have to see for the sugar levels whether they are normal or abnormal. And plus, if patient is have a pain, then we can add a analgesic. If patient is having a vomiting, then we can add a antiemetics. And she's, I think this is all.
Regarding this bed rest, what is your opinion? Should
Bed
you
rest I
advise it?
don't usually say because for bed rest is nothing. It's adding. I mean, it's not a
Yes,
supportive treatment. It's not adding anything. So
yes,
I
yes. So,
usually don't say the bed rest to the patient.
yes, definitely. So,
Here we can
expecting
just reassure the patient also that small little bleeding is not a not
Yes.
a problem. And
We
she's
should know. We should know how much bleeding, how much patient is bleeding,
Mhm.
spotting or heavy bleeding. Then we have to counsel according to that. But
Hmm.
the bed rest again, bed rest is not advisable.
Yeah, definitely. So, advise on red flags and then ask her to come after 1 to 2 weeks to confirm the all week viability. Now, is progesterone supplementation indicated at this time and for whom? So, any one of you can answer. Who, rather, I will ask everyone. Whosoever is giving progesterone and what dose and what
I will add.
age.
Although the guidelines say if there is a recurrent pregnancy loss and the patient have bleeding or one loss, then patient
Yes.
bleeding, then you add. But I add progesterone in all the patients. If
So,
patient is
what
having
I
what
I
what
normally
progesterone
do
and what dose?
sustain vaginal pastry, 200 milligram twice a day.
Okay.
so I in my patients with the early pregnancy do progesterone for everybody so that I know which are the patients who require the progesterone and which are not. So in case her progesterone is with, I can explain her that can always take the sustain or the vaginal suppository 400 twice a day. In
Mhm.
case there is any history of abortion, previous abortion,
Mhm.
then also I'll suggest irrespective of the progesterone values.
So you are getting the progesterone done in each and every progesterone, whether it is spontaneously conceived or after
Ma'am,
ART.
it depends if she's bleeding and she has a history of miscarriage, then yes, I'll give her.
So what is the cutoff you take for progesterone?
In the patients, ma'am,
Yeah.
more than 10. 10. If it is more than 10, then it's okay for me.
So if it is more than 10 and still she has come with bleeding and with this kind of sonography finding.
So I will tell her to take rest. In case her bleeding doesn't stop or it increases, then we'll see I might then start the progesterone for her.
Okay. So others, please also tell your experience. Dr. Shalu, Dr.
So
Natasha.
I think as others have said, the guidelines do not support any progesterone supplementation, and
Yes.
I also generally do not start progesterone. But yes, if they have history of previous miscarriages, then Again, the guidelines do not show, but I also start progesterone in those who have previous miscarriages, and definitely in those who have, who have presented with second miscarriage. Otherwise, for primary, I would not start.
So definitely, all the literature says that there is no significant benefit overall in giving the progesterone in those who have first time this kind of threatened abortion. The PRISM trial also said that no significant benefit there, but the benefit emerged only in a pre-specified subgroup where the woman with bleeding and a history of one or more prior miscarriage. There was the effect or the advantage of taking progesterone. NICE therefore updated its guidelines in 2021 that offer vaginal micronized progesterone to women with current bleeding and a prior miscarriage and continue it to 16 weeks, but not to women with no such history. But in practice, I think every one of us who are practicing OBS, we are giving progesterone to those who have come to us with spotting. I think every one of us giving, especially micronized progesterone or Dufaston, whatever. So there was again another study regarding the role of progesterone in women with threatened miscarriage or recurrent miscarriage, which was a meta-analysis of 15 RCTs, and it also concluded that in women at increased risk of pregnancy loss, progesterones probably increase live birth without increasing the adverse maternal and fetal effects, and the benefit is restricted to those with prior miscarriages. But yes, in practice, we are all giving progesterone to these patients.
Can we take the opinion of Surveen? Hi, Surveen, can you give your opinion here?
Yeah, so
yes.
See, I feel that progesterone really does no harm. So if there is a chance, why not take it and give progesterone?
Yes,
That's
yes.
what I feel.
And also the patient also feels that something is
added.
Something is added, and if I was the patient, I would try everything myself, right?
Yeah,
I
definitely.
would want progesterone to be given, even if there is, let's say, 1% chance or 2% chance.
Yes, yes, yes.
I would like.
So I just wanted to know one thing: if the patient is bleeding, and having spotting, do you all recommend vaginal progesterone, or do you think
No,
of any
no,
other
not
route
at
as
all.
well?
Not with bleeding.
Yeah.
Channel is not recommended because it
So-
doesn't get absorbed that well.
What
So-
is your preferred progesterone dose, and what is the this thing, dydrogesterone or micronized vaginal progesterone or
So,
oral progesterone?
if she's not bleeding, it's micronized vaginal progesterone. If
Yes,
she's
ma'am.
bleeding, then it's dydrogesterone.
Okay, okay, and that too in TDS dose.
Yeah, TDS.
10
If
mg
she's
TDS.
bleeding, then TDS. You can't have
Yes.
lower dose.
Now, if she is an RH negative, is NTD prophylaxis required in threatened miscarriage before 12 weeks? What is your opinion? Anyone can give the answer.
Depending on the amount of bleeding and if patient is having pain, then we give the NTD, otherwise not.
The current NICE guidelines say that before 12 weeks, if the RH negative patient is there, then a prophylactic anti-D has no benefit.
But if
This
patient
is
is having
different
yeah.
from the older concept.
But newer guidelines also say if patient is having a pain and increased bleeding, then you have to give the NTD.
Yes, major recent guidelines they have moved away from the routine NTD for threatened miscarriages before 12 weeks. But yes, some older and regional guidelines still recommend a minimum dose of 250 IU if bleeding is heavy, repeated, or accompanied by pain as gestational age approaches 12 weeks. Yes, true.
Yes, Dr.
So
Neelam, I just wanted to add one thing. If this
Yes.
we are thinking this is a normal or ongoing pregnancy, then NTD it is not recommended for less than 12 weeks. But suppose if we are planning the termination, so the
Yes.
government of India says
Yes.
less than 12
Any
weeks we have
intervention,
to
yes.
give.
If
Yes.
intervention is done, then definitely you have
Definitely,
to.
Yes.
Then again, there is a controversy. If we let her go for medical abortion, like misoprostol or something, should we give?
Yes. Yeah.
Or,
So government of India, Dr. Neelam says we have to give NTD. Okay, but WHO and other bodies they restrict giving the NTD, but we have to go as
Yes.
per the government of India, so we have to
Yes.
give NTD if we are doing the termination.
Whether
Less
it
than
is
12 weeks.
medical or
also.
whether it is surgical.
Yeah,
Right.
either medical or surgical.
Definitely. So, what intervention that lack evidence and should not be routinely offered to these patients, like HCG, tocolytics, hospitalization?
or strict pelvic rest. I think these should not be advised because they are not supported by trial evidence, and I don't think we all are doing this. HCG is gone from this treatment of threatened abortion. So now this patient came again, and we did the repeat scan after 7 days, and the embryo was CRL was 7 mm, cardiac activity was 108 beats per minute. Now my question is, in embryos with demonstrated cardiac activity, which additional sonographic features signal an increased risk of early pregnancy loss? So what are the features in very early pregnancy, like 7 weeks, which can give you an idea of or risk of early pregnancy loss?
Retroplacental clot.
That is subchorionic hemorrhage. Yes.
Subchorionic hemorrhage, yeah.
Yeah. So there are 4 findings. That is embryonic
Can
bradycardia,
be
small gestational sac relative to the embryo, large yolk sac, and a subchorionic hematoma. But none is individually diagnostic of impending loss, but each shifts risk upwards and supports closer interval follow-up rather than the routine interval assurance. So what heart rate threshold defines clinically significant embryonic bradycardia? Now, Dr. Natasha, you can give answer. What fetal heart rate at 7 weeks you define as embryonic bradycardia? Or anyone?
Less than 110.
100.
Less than 110.
110.
Yes, according to the gestational age, there was a very old study that was in 1994. Benson and Dobilet Samanal series found that an embryonic heart rate less than 90 bpm before 8 weeks carried a poor prognosis, with demise occurring in all embryos with a rate less than 70 bpm. And this was the table he has given, that if the gestational age is 6.2 or less, if it is 80 less than 80, 100% demise will be there. More than 100, there is 11% risk of demise. Similarly, so this table is still useful in many of the studies. And again, there was a meta-analysis of 80 studies, and they found that fetal bradycardia had a sensitivity of 68.4%, 97.8% specificity regarding the pregnancy loss in women presenting with threatened miscarriage. And the best performing cutoff was less than or equal to 110 bpm. And therefore, these authors recommended a repeat scan at 7 to 10 days rather than an immediate diagnosis. So if there is embryonic bradycardia of less than 110, it is better to do it again after 1 week. Now, how should the yolk sac size, shape, or absence at this gestation influence counseling and follow-up interval? So you can see this is a large yolk sac. So what yolk sac size may make you think that it may go in miscarriage, or it is not a good prognostic sign? Dr. Tumi, Dr. Sugandha, anyone?
Can I?
Yes.
More than yolk sac, then the yolk sac being more than 3 mm, it gives me I'm little skeptical when I see it. I just write it down. But yes, if it is more than 4 mm or 5 mm, then yes, the prognosis is on the poorer side. Though I have seen normal pregnancies even with the yolk sac of between 4 and 5.
Literature says that yolk sac more than 7 mm has been proposed as a concerning threshold. Then we label it as a large yolk sac. And the diagnostic performance of miscarriage prediction at this diameter is sensitivity is 17 to 69% and specificity is 79 to 99%. So also the shape of the yolk sac, if it is irregular, collapsed, or even calcified, or when it is absent, when the mean gestational sac diameter exceeds 8 to 13 millimeter, they are also additional markers which suggest that the prognosis is not good. But again, to emphasize, it is not a reliable standalone predictor of pregnancy loss. We have to see other markers also. Now, what defines a small gestational sac and what miscarriage does it carry? So you can see this is a very small gestational sac, but the CRL is good enough.
So
the small gestation sac is when the distance between the CRL and the sac is less than 3 mm. Then it is called
less
as a
than
small
5
gestation.
mm.
5
Yeah.
mm, sorry. Less
Yes.
than 5 mm, it is called as a small gestation sac.
So you can see that the embryo appears sonographically crowded in the sac, and it is associated with a miscarriage rate as high as 94% in that particular study. And there was another study, recent cohort of IVF pregnancy, and found a lower but still markedly elevated loss rate of 43.7% with MSD minus CRL of less than 5 millimeter. So this is again an important predictor of miscarriage. Now another one is subchorionic hematoma. So the question is, does a subchorionic hematoma meaningfully change prognosis, and does its size matter, whether it is small size or it is such a big size? So what is your experience?
So we have to hurry up, Neelam, because it's already
Small size
6:30.
usually
This is the
resolves.
last slide, the last slide.
Small size usually resolves. We have to just follow up. Large size, then we have to be vigilant,
Yeah. So
very
sometimes when it
cautious.
covers,
Yeah.
large means, I mean, yeah, more than 50%.
Yeah,
So
that
that
means
carries a
Yes.
poorer
increased
prognosis of
chances of
miscarriage.
miscarriage. Yeah.
Yes.
Also, when there is subchorionic hematoma, you have to be particularly vigilant about the increased odds of not only miscarriage but stillbirth, preterm birth, and especially when the hematoma exceeds 50% of gestation volume. So, yes, that's it. That's it.
So thank you, Neelam. It was excellent. And let me have two more cases. Let me see how much time we have left. And so can you stop sharing and I'll just share? Okay. Mukul,
Ma'am.
can I add my presentation here?
Yes, ma'am. You can.
हो गया दिख रहा है? Is it okay?
हाँ जी दिख
Yes,
रहा है.
ma'am.
Acha. Oh, thank you. So I think we'll just go faster now.
Full screen कर दीजिए ना इसको ना.
Just a minute. I'll do that. Is it all right now?
Yes, yes.
Okay, so we go with the next, and I think all the panelists are ready. So we have a 32-year-old female, second gravida para 1 at 9 weeks presence with vaginal bleeding, and ultrasound confirms a non-viable intrauterine pregnancy. Now she's hemodynamically stable, afebrile, HB is 11.2, no significant pain, and she says, I don't want a surgery, but I also don't want to wait for weeks. So I want to know from the panelists, what are the options and what any of the one by one, all the panelists can give their what they want to. Will they go for expectant management? Who will go for medical? Who will go for surgical?
Since
Ma'am,
So
so
in
if
this
I can
Kaustya,
answer,
can
yes.
we?
Yes. So, as she's hemodynamically stable, we have all the options, but because she doesn't want to wait for longer, so we can definitely go ahead with the medical management.
Okay, so Juhi goes with that. Parul?
Yeah.
But medical management, because expectant will take a long time, 7 to 14 days. Surgery, she doesn't want surgical management. So we
Okay.
left with the medical management only.
Okay. And what about the, I think all panelists agree with this medical management?
Yes,
No,
ma'am.
I
Can you
would,
help us with the
Doctor
medical?
Renu, I would counsel the patient for suction evacuation. See, she has come with bleeding. Okay, I have to counsel that she has to change her mindset. She has come with bleeding, and if I give a medical management, MIFI or meso, if I'm trying to put her on, she will bleed again. Okay, right now she is hemodynamically stable, but later she may not be. So the best for this patient is a suction evacuation at this state. But still, if she doesn't agree, she wants only medical, then we can give MIFI meso or maybe alone mesoprostol. But
But
best is the
Chitra,
suction evacuation.
I got your point, but since she's not bleeding very heavily, it's not an incomplete abortion. So why can't we go
Yes.
for a lesser invasive procedure for the patient?
Yeah,
My
that is fine. That is fine. But medical management also, Dr. Renu, she will have a bleeding. And once we start medical management, we have to ideally wait for at least 1 week. It's not key we give MIFI and after 24 hours we give meso and the very next day we do a scan for the completion of procedure. We have to wait for 1 week if we are trying to put her on medical management.
So that is what we are trying to debate on this. So this was a literature which said expectant management obviously is non-invasive and all that is there. But medical management is, it predicts completion now. Usually it predicts completion. They are going on very well now, these medical abortions. Nobody is going for surgical because of the risk of, adhesion formations and all that. But that patient can be counseled that this is going to happen. And 1% or 2%, if she bleeds heavily or something like that, then patient may be taken. So that is one. So medical abortion. Okay, next I want to know what medical abortion you wants to go. So for this, because is all that we all decided that is she's going for, except for Richa because she wants to go for surgical.
No,
We all
I
go
just
for medical management. Okay. So now, which type of medical management you all are giving?
Myself,
mifepristone and misoprostol, it
and
works the best.
misoprostol.
Mifi plus Mizo, ma'am.
Acha, this
These
question is for Richa. Let me ask Richa first. Richa, I know you are going for surgical. Can you choose anything from this? Are you doing medical abortions or not?
Yes, we are doing medical
What do you
abortions
do in
and
your practice?
and we are using mifepristone and misoprostol.
Okay.
And the results are very good. Expulsion rate usually, what is literature says also, is 99% expulsion rate is there. But if the mifi sometimes it is not available, then I do prescribe misoprostol also. The results are more or less same.
So what dose of misoprostol are you giving?
This patient is 9 weeks.
Yeah.
It's okay. So if the patient is less than 10 weeks, so we give 200 of mifepristone, and then after 24 hours, minimum interval is 24 hours, and then 800 micrograms of meso we give if she is less than 10 weeks. But if she is more than 10 weeks, then we can repeat the dose after 3 hours also, 800 micrograms. Then again, we can repeat the dose also after 3 hours.
So this is what I want to ask you, Richa. You said you are giving Mifi 200 and then misoprostol after 24 or 48 hours. That is all the literature.
24 to
What
36
about the
hours.
repeat dose? No, you are saying the repeat dose you will give after 3 hours. Why? Why you want to?
This is for misoprost I am talking about. If the patient gestational age is less than 10 weeks, one single dose is enough. But if the gestational age is more than 10 weeks, then if she has not expelled, we can give after 3 hours also. This is for misoprostol. The
Okay, so
Mifi, the dose remains the same. Yeah, this is as per the guidelines of FIGO 2023.
Yeah, I'll just show you that. So everybody is agreeing that we give 200 and misoprostol 800 is given 20 to 48 hours. And usually we are giving vaginal. I think everybody is giving vaginal. We are not using
Vaginal is,
And even all these guidelines are recommending that all these for missed abortion less than 14 weeks. Less than 14 weeks, everybody is doing, except for ASUG, which says 24 hours. The rest, everybody is giving mostly after 24 hours. Okay, so regarding why this combination is better, actually, now the lot of studies have been done and they have found that if we give meso alone and the comparison have been done with Mifi plus meso, they said the combination is better. There's complete, it is less of a this thing, failure rate is less. That is why Mifi and meso is being given now all over. Everybody is doing that. And regarding misoprostol, this was a study, interesting study, which was done in misoprostol versus misoprostol. This was a Mifi-Miso randomized control study, and they found that the failure to pass the gestational sac was around 24% misoprostol alone, whereas in case it was only 17%. So I think everybody has changed now. Even we were initially giving misoprostol, but now we have also switched over to Mifi plus meso. Okay, there are all similar studies which are recommending Mifi plus meso rather than misoprostol alone. So this was the medical regime which now this has been published in 23. I think this was a study done only on missed abortions. And just see here, they have said that the dose they have given is 200 and then followed by misoprostol around 800. This is Mifi 200 and meso. Then at times, Richa, we have also seen that the patient doesn't expel. Then what do you do next?
Then if she is more than 10 weeks, we repeat the dose of meso.
How
Same,
much?
800.
Yeah, after 24 hours.
No, this I am talking about misoprostol.
No, you
See,
don't do that.
Mifi,
I'm just saying Mifi plus
Dr. Renu,
meso.
Mifi, Mifi dose remains constant. We don't have to repeat at all. So Mifi is 200 with that we have given. Then after 24 to 36 hours, we give meso 800. And if she has not expelled, then we can repeat the dose after 3 hours.
Okay, but 3 hours.
This is we were actually not using the repeat dose, but now we are following this because FIGO also recommends you can repeat after 3 hours. This is beyond 10 weeks.
What do you mean? But you waited for 24 hours after misoprostol, na? That's what I'm saying. See, you're given.
Again, it depends upon the clinical findings. If there's no progress at all,
there is a lot of confusion regarding this. What people
because if she has to abort, she will abort in 4 hours maximum. She will start the procedure starts in 4 hours. But if there's no sign at all, and then we can repeat the second dose also.
So, matlab, you can even be a bit slower. So we can wait for 24 hours.
Yeah, after then we can tell her she's in failure.
Wait for 24 hours, and then if it doesn't expel, then maybe after 24 hours of the misoprostol, we can again use 800. That is what this study was telling. Because all the studies I was trying to find out what is the next dose that is to be given if there is a failure. None of them recommend it except for the misoprostol regime, which is FIGO. FIGO is going the different way. That is only for misoprostol where they are giving 400 every 3 hourly or 2 hourly, right? But for less than 13 weeks, maybe it is misoprostol 800 plain. Even if you want to give, then you wait for 24 hours and again repeat it. So that is what. So Parul, I want to know, when is misoprostol alone appropriate?
When
कोई
there
ऐसी
is a
condition है आप डालना
incomplete,
मीठी नहीं देना चाह रहे हैं?
नहीं देना चाह रहे, when incomplete abortion is there, already the
Okay.
process has started, os is open, then we can give the misoprostol.
What dose will you give?
600 or 800.
So there's a lot of variation. Usually people are giving 600.
600 because 800 is a high dose for
And
incomplete.
yeah, and for even for these medical abortions, if there's history contraindication for mifepristol, all these, like if there's previous allergy, severe uncontrolled asthma, contraindications, matlab, adrenal failure, inherited porphyrias, or long-term steroid, we should not use mifi for these patients. Only misoprostol has to be given in these kind of patients. So this is what I wanted, that everybody should know the contraindication of not giving mifepristol. So, okay, counseling regarding bleeding and pain. Do you give anything for pain management, Juhi? Juhi?
Yes, ma'am. So I usually give them NSAIDs for pain management.
What
There's
NSAID?
nothing like, so simple paracetamol, also the Flexon, I mean the combination, and the Buscopan or antispasmodics, rotavirin. So these may help for the pain management. And
That's
there's
fine.
nothing like, if we give NSAIDs, it will oppose the effect. Now it has been well proven, so we can safely give them.
So that is there. So people are doing given NSAIDs, and dose is like anything like 400 or 800 milligram that can be given. And I do agree with you about the painkiller. Yes.
Right. So
Shalu,
along with
yes?
the painkiller, I tell my patient to use hot pad. Ma'am, I tell my patient to use hot pad also, along with the painkiller.
Hot pad? Acha.
Yes, ma'am, it
Okay,
helps
that's
in the contractions. It helps in the contraction. It
so per
smoothens the tummy
abdomen,
and
per
it helps
abdomen.
per
Per
abdomen,
abdomen.
per abdomen.
Okay, okay.
Yeah, yeah.
Could be used. Okay. So, Sugandha, I wanted to ask, when should treatment be considered unsuccessful? When do you think, and what do you do next? Though we have talked about this. Anything
If
you
the
differ, Sugandha?
Yes, if patient has constant bleeding and hemodynamically any hemoglobin level has fall, if any counts have raised, any patient gives any history of infection, severe bleeding, um, severe pain, then definitely medical management has failed and we need to surgically intervene.
Okay. So maybe if she's bleeding
Good
heavily,
evening,
then
ma'am.
you have to.
Good
Yes.
evening.
Good evening. Who is there? Okay. So, Shalu, can I ask what suction evacuation, when is suction evacuation appropriate? They are usually the same things. Do you do, like, after failure of this medical management, do you go for this suction evacuation?
Yes.
You do plan these patients for, like, after giving 2 doses of misoprostol 24 hours apart, or you just take them away, like one mifi meso, and then you take them up for suction, surgical evacuation? Shalu?
Hello. Yes, ma'am. Sorry. So, ma'am,
No.
I do take them, but only when my RPOCs, it is at the size is a big one there, more than 25 mm or something. Then I go take these patients for a suction evacuation because I'm more apprehensive about the adhesion formation. So, being
Okay.
an infertility specialist, I really feel this infection and this. That is
So
it.
in your practice, are you doing ultrasound guided, like
Yes, ma'am. I
evacuation
do
without?
ultrasounded guided.
I am
Yes.
also doing ultrasound guided.
All are doing ultrasound, and I think private everybody is doing ultrasound guided evacuation. Now, has anybody tried about this manual vacuum aspiration,
No,
Natasha?
no, just saw in the video, but never tried.
No, ma'am, I think I'll be speaking. I do a lot of manual
Very
evacuation aspiration because they all RPOCs which are there. But my because it is available, if you go for the manual, you are able to get the syringe, and we do it here in the OPD. I just tell my patients to take one small Combiflam and come. Normally, their internal os is open, and it is very easy to do it.
That's
But I
great. I
tell
think
them with this, I tell them that there is a chance that it may retain, I may do it, but they are my patients are more than happy that we are saving from the surgical thing and we don't have to undergo the anesthesia.
How do you do this? Are you doing under cervical block or just any IV sedation? What do you do?
Ma'am, only the Combi-Flam will do because internal loss is open. I don't have to do much here. These are the one who are very small tiny bits and they are just spotting and that is these
No,
ones.
that is for retain. I'm not talking about retain. I'm
Yes.
saying beefy misoprostol has failed. Now the next step is you are going for surgical. Then you are using a vacuum aspiration for them. That's what I wanted to know. Is it like
No, ma'am,
incomplete?
not for the retain, only for the retain. So
Only for the
incomplete.
So, Reen, I wanted to know your opinion. What do you do in your practice?
I don't do manual vacuum. I do a suction evacuation.
Suction evacuation under
Yeah.
GA. If she has
Under
failed,
G.
we take
Under
the
G.
under G.
I just feel that it's a vaginal procedure. I really wouldn't like to have it done on myself. So why should I do it on patients? I would like a GA and then whatever procedures to be done. So I'm very clear. All my vaginal procedures are done under GA.
Yeah. So I think after doing a failure of the medical management, I think suction evacuation under ultrasound guided under GA, I think that's the next option better. But
Yeah,
all
because
the guidelines,
you can't have a second failed surgical thing. You have to
Yeah.
be
you have to do the
Very
complete
sure.
course. Yeah.
You should be
You have
very
to do the
sure.
complete
Yeah.
course. You
Yeah.
can't
This is
think
the
you wait
best
for
method.
another week and then come over.
Yeah,
I
yeah.
also do agree. I think that is the message which has to be taken. And I think a lot of books are talking about this manual vacuum. All the latest guidelines are talking a lot about manual vacuum aspiration.
You know what happens? I'll tell you with these guidelines, they do a cost benefit analysis.
Yeah, yeah.
So they actually not real world things. They're doing a cost benefit analysis on a patient who can afford everything. So why do that? You know, and in government hospitals also everything is free of charge. So why?
So that is there, but I think vacuum aspiration can be a better thing. If any, I think more of randomized
Definitely.
controlled trial should be done on these things. Then only we can come to a better conclusion. But yes, they said the Asherman syndrome, this thing is lesser in these kind of, it's less traumatic as compared to the surgical evacuation which we are doing.
It really depends on who's doing it.
Yeah,
You
that
know
is
when
also
to
it.
stop is the important thing.
So I just wanted to have a thought regarding this vacuum aspiration. A lot of guidelines are talking about, but I think we need more of RCTs at least then to discuss whether this is really going to help. And then maybe if the Asherman syndrome is less, we can think of doing this as well. So they said it can be performed as an outpatient procedure. Local anesthesia you can give, it is rapid and avoids prolonged waiting. So I think it may work for many people, and it is also working for incomplete abortion less than 14 weeks. Anybody can try that.
And manual vacuum aspiration requires proper selection of a patient because all the patients can't be put under this category.
Yes, yes, that selection is for everything. I think for any patient, whether you want to do surgical, you want to do medical, that proper selection is there. Obviously, we had talked about this risk of uterine adhesions, repeated instrumentation, and all that is always there in these kind of evacuations. Now, this is, they said, when even they have compared the ultrasound guided manual vacuum aspiration and electric vacuum aspiration. They found the intrauterine adhesions were very much less in this ultrasound guided vacuum as compared to the electric suction evacuation, which we are all doing, which is around 38%. That is why I brought this slide forward, just to let everybody think on those lines. So, any role of hysteroscopy anybody is doing?
No, ma'am.
No, not for
We
any
do,
this.
Dr. Renu, we at times we do hysteroscopy if we find a persistent RPOC is there. Like no patient, she has undergone medical management or surgical management. Then again she comes with spotting, and we have done the scan. Okay, then we give a 600 meso also. She has expelled, or sometimes they don't expel, and we do the scan. And then RPOC also, we the picture also is confusing because there are various types of RPOCs from avascular
I'm
to
just coming to that.
highly vascular. So those
just-
cases we do, and also the cases who are referred from outside who had undergone twice and thrice, sometimes they undergo DNC for bleeding. So those cases also we take up and do hysteroscopy.
Yes, I think hysteroscopy is more for those retained kind of things which have been repeated. Surgeries, suction evacuation have been done, and then maybe in those hysteroscopy has a role. So now this woman chooses medical management, and 3 weeks later, she again comes with persistent bleeding. This is what we all see routinely happening. Now she reports persistent spotting, mild pelvic pain, no fever, no heavy bleeding. When we do an ultrasound, the annual thickness 12 mm. Heterogeneous intrauterine material seen, and there is minimal vascularity. Now I want everybody's opinion. Natasha, is any intervention necessary for this patient? Natasha? I think it's Natasha.
Ma'am, am I audible?
Yeah, hi. What will you do, Natasha, regarding this?
Ma'am, in this, I will definitely go for
Can you be louder? We can't hear you.
Am I audible now?
Huh.
Bit more louder.
So since it's been now 3 weeks, I believe, for the patient, this is one patient who I will give an antibiotic, and I probably might take her for hysteroscopic guided or otherwise suction evacuation in this patient after doing PT, INR, and coagulogram.
So with this ultrasound thickness of 12 mm, heterogeneous intrauterine material, many will you take this patient for evacuation?
No.
No.
No, this is her
Let us
opinion.
check
I just want
the
to repeat.
This is not
vascularity
a,
above for it.
It can be a clot. It can be a
Let's check
clot.
the
this is
vascularity
not
to
a
understand.
indication for doing a
Because,
surgical
yeah,
evacuation,
because
just
this is
on the basis of endometrium.
because this is only a minimal vascularity. It can be a clot. So we can
Yes.
basically,
So that
instead of
is very
intervention,
important, Natasha.
follow.
If we like, even the endometrial thickness is, but it is showing minimal vascularity, and
Hmm.
only maybe it could be a clot. That could at times, people just start doing that. That is what I want to tell. It's not necessary. We can wait that she's having spotting, because all these medical abortions, they usually take 3 weeks of spotting. That has to be told to the patient. So if she comes, maybe we can just give them some antibiotic, or we can keep the patient on follow up and then see next how is this happening.
I said,
So
take coverage and also do a coagulogram on the patient, and probably
that's okay.
then I would go for hysteroscopic.
There is some indication of hysteroscopy, which I will tell you. So this is the normal post mis. Everybody should know how a normal post miscarriage uterus looks like, and what is the difference between retained product of conception. So people get confused between just the changes with the thickened endometrium is there post miscarriage and the RPOC. See, if the endometrial thickness is more than 8 mm, it could be there in cases of post miscarriage. But in cases of RPOC, there is no definite guideline regarding the thickness of the endometrium. Whatever literature, anybody who takes any cutoff for endometrial thickness, that I will not touch this patient. Sugandha, do you take any cutoff? कि इतनी endometrial
And
thickness तो मैं कुछ नहीं करूंगी.
I think diagnosing RPOC or anything should not be based on the level of the endometrium. Because
Yes.
even if the endometrium is 12 mm, 10 mm, I don't think it matters. Only vascularity is there, or some prominent mass is seen and it has vascularity, then only it can be confirmed that this is RPOC. Otherwise, with minimum vascularity, any endometrium, and endometrium sheds over the time period.
Yes.
So
Ma'am,
you
but there
can't.
are some of the
Shalu, you can
guidelines
say.
which says there are some guidelines which says 25 mm, the thickness of the RPOC, if it is more than that.
That's quite a big, actually,
That is
whatever
the
guidelines I said,
2.5
15
centimeters.
mm was the
15,
cutoff.
yes. We also take a
I would-
asymptomatic patient, 15 mm. We also
15
take a
mm.
cutoff.
All the
Yes.
guidelines are saying 15, Shalu, whatever I read. And though they said there is no such, but 15 was the maximum all the guidelines have taken. So maybe that is one thing. So more than 15, any minimum vascularity, we can take the patient, remain on follow-up, and then again call the patient. So all these are said, there's no universal reliable ultrasound criteria for after first trimester pregnancy loss. And various studies have taken 18 and 15, and 15 being the most this thing, and they said there is no universal cutoff. So along with that, what I want to tell, that only endometrial thickness, what Sugandha said was correct. I think you have to keep on seeing the vascularity, the Doppler with the Doppler, and then decide what and any mass which is seen. But as such, minimal small clots can show minimal vascularity. We have to leave the patient alone. So this patient, no evacuation is required, and then we can just follow up. So this is again, they are saying ki no, not on the basis of ultrasound finding, but yes, vascularity, retained products, and then you have to take a call whether repeat has to be done for the patient. So this is how they said ki if there is more vascular intracavitary mass is there, if you see any heteroechoic content with enough vascularity, that should make you decide that it is a retained POC. Then only you should take the patient for the intervention, whether hysteroscopically or maybe suction evacuation under ultrasound guidance. I think that will help for the patient. Again, this is a 2025 systematic review, and they said absent vascularity or min does not say that you have to go for an evacuation. So this is again the same things. More concerning always should be a hypervascular RPOC. That should be the main thing. So again, this patient had similar things, and the NICE recommend that repeat scanning when bleeding pain persists or increases after the expected period of management. So if the patient again keeps on repeating coming up, maybe then the patient requires a hysteroscopy. That I think we should all do, and then see what is the problem with that. Okay, so this is all the same things which we had talked about. So now this is the role of hysteroscopy. Richa, you can come over and tell us. This is what you want to do, no? Hysteroscopy.
Yeah, this is what I told. No? If we have a persistent RPOC and patient is symptomatic, she's coming with spotting. Those cases and other referred cases also many times we get, who has undergone twice and thrice DNCs for bleeding, and then they come. So many times we find features of endometritis also, and then RPOC also. So usually, as what
It's a
we have
mixed picture,
said,
at times it's a
yeah.
mixed picture.
So we give antibiotics, we wait, and then we take a decision. We don't straight away take the patient for hysteroscopy.
Okay. So it's focal intracavitary RPOCs, persistent RPOC after previous evacuation, ultrasound findings are equivocal and symptoms are persisting. Then you have to take, and maybe if she's she's infertile, then or maybe I don't agree with this, but maybe first three are more important for all of us.
And also, Renu, I had a patient where a AV malformation was detected on ultrasound. So their histoscopy again is important.
But regarding, yes, I do agree. But even if we do histoscopy in these AV malformations, because they are the vascular channels between the myometrium and the endometrium, I think in histoscopy we'll not be able to see anything as such in them.
No. You'll just avoid that area. That's it. When you're taking out the POCs.
Usually it's
basically to avoid.
Yeah, that is there. Just go inside and just come out so that there are no brain products. Because I think with AVM, we have to go for some embolization kind of thing, uterine artery, because they bleed like anything at times if you touch them.
Even the interventional radiologists, they say that I did the same thing. Embolization was done, and post embolization, he referred the patient to me for hysteroscopic removal of the focal mass.
Yeah, I do agree with that. And that is better way of dealing with the patient. Anybody who gives antibiotics to these patients? What all of you give antibiotic after medical abortion?
No, I don't.
No, not
No, we don't.
So
Not
those
routinely.
recommendations are not for only for surgical, that we have to give antibiotic. So what antibiotic are you all giving if you've done a surgical abortion? Anybody?
Cephalosporins.
So usually people are giving they have recommended guidance, azithromycin 1 dose. They said even doxycycline 1 dose for surgical. They are just saying only pre-operative. But I think because of the Indian scenario over here and because of the hygiene, we are usually giving for 3 to 5 days at least post-evacuation. I think so Raveen, do you agree with that? The antibiotic are you routinely giving?
Absolutely giving. We are giving.
So that.
And mainly our patients are infertile, so we're very scared of any kind of intrauterine infection and adhesions.
Yeah, that is there. So this is with the first case, and I don't think so we have time, but we had one intrauterine, twin pregnancy, which I wanted to discuss. So Mukul, do we have time? Or should we wind up? Surveen?
Yeah, it's 7 already, no?
I think, Mukul, are you there? What time we have till?
Hello?
7.
Hello?
Yes, ma'am. 7 people.
7 minutes?
7 हो गया मैम, ये 2 मिनट रह गए.
2 मिनट रह गए मैम.
Chali. Okay, I think then we don't take up this. I think the first case was too long and then maybe this one. So thank you so much, everybody. And thank you, panelists. Thank you, Surveen, for being with us and giving your expert opinion.
Thank you, ma'am.
And thank Farul, all the panelists, Shalu, Natasha, Ganda, Richa. Thank you so much.
Thanks, Renu. It was really nice being on board with you.
Thank you so much. Thank you,
ma'am.
Thank you.
And I thank the Haryana chapter, everybody. Now I request Namita to give a vote of thanks, please.
Thank you, esteemed panelists, speakers. It was a wonderful, informative session and looking forward more to such sessions. Thanks a lot, everyone, and especially the participants for their interactively they had participated. Thank you, everyone, once again.
Thank you so much. And I thank the Haryana chapter, Meenakshi and Urmila for being with us and giving this opportunity. Thank you so much. And thank you, Bhagya. Thank you, Bhagya, so much for conducting it so well. It went so smoothly. And thank you, Mukul, for being with us all the time. Thank you so much.
Thank you.
Thank you.